Okay. Looks like everybody's here, so we'll get started. This is course be a little bit. It's going to take me a little bit of time to get all the slides done. So just know that I'm about a week ahead of you. So I'm constantly making slides and making presentations. So your notes won't be up ahead of time. They're going to be up by the time of lecture, at least. Okay. So be understanding of that. I've taught pharmacology before. I used to teach it a long time ago. And I teach the DNAP. I teach part of the pharmacology. So, it's something that I've taught before. So you're going to get a very different kind of feel for it because the way I teach pharmacology is that I try to teach it to what we do. Okay, so everything that I talk about is what we actually do. And I'll show you a lot of application tricks during these lectures. Okay, so if you don't pick up on all of it, because sometimes it's a little subtle, and sometimes you just don't have any understanding because you haven't really worked in the clinical yet. These are great lectures to listen to once you get to clinical, and re-listen to them. Because then it's sort of like, I know what I'm having trouble in clinical, and I don't understand how this medication works. These are the kind of lectures that they're application-based. Go back and listen to them when you have a chance. And they will be left open for you guys when you get into clinical areas as well. Okay. Anytime you start on pharmacology course, the first discussion should be on pharmacokinetics and pharmacodynamics, okay? Because these are very fundamental discussions on how medications work. When we're talking about pharmacokinetics, you're talking about what the body does to the medication. In pharmacodynamics, it's what the drug does to the body. If you just keep it simple like that, it makes more sense. Okay? So the first thing we're going to talk about today, which will only cover 66 slides, it's about a 2-hour discussion, is on pharmacokinetics, is what the body does to the drug. We're going to go over principles of absorption, distribution. Then we're going to talk about metabolism and elimination. Many of our medications that we're going to talk about initially, which is for the first 3.5 weeks, we're going to only talk about pharmacodynamics, pharmacokinetics of inhaled anesthetics. So I'm going to spend all that, about a total of 9 hours, just on inhaled anesthetics. These are a majority of our practice, so you should really understand how this stuff works. Pharmacokinetic measurements that are available out there, you'll hear different terminology, so it's consistent with giving you a little bit of vocabulary. You'll see me use quite a bit the word bioavailability. What basically that means is how much medication is really available to bind to the receptor. Okay, how much of it that you're dosing eventually gets to have an effect. Okay? So it's really the rate or and extent to which the active ingredient pharmaceutical equivalent becomes available at the site of drug action. Now, we bypass a lot of problems with bioavailability by giving medications directly intravenously. Okay? When you give things enterally, which is PO, you have a lot of problems with bioavailability because it depends on the person's pH of their stomach, depends on the absorption rates of the GI tract, it depends on how well the liver is working. So all those things have big factors which we don't have to worry about. Our medications are much more consistent, but they're also much more lethal because of that. Okay? You don't have much play with more medications. As for clearance, clearance can be broken down into 3 concepts. Some books will make it just 2 concepts of metabolism and elimination. I think the other one that I think you should consider as clearance is redistribution, okay, which some people would put as separate, but it doesn't really matter. It's a way the medication goes away from the site of action that you want, so I consider that as clearance. Volume distribution is a fairly difficult concept for a lot of students to understand, but because they think of the body as just being one size. But actually the body is set up of separate compartments. Okay, you have vessel-rich group areas, which we're going to talk about in detail, like the brain, the heart, and the kidney. They get saturated with blood medications quickly, okay? Versus you have other ones that are medium, which are like the liver, or you have muscle, it's also medium-rich groups. Then you have your really slow reaching blood groups like fats. And each of those compartments can fill with different amounts of the medication. And if you're able to fill all the compartments, the volume distribution is actually very large. Okay? If you're only able to fill the blood because it's a very insoluble agent and it doesn't want to go into the tissue, then actually that volume distribution for that drug is very small. Okay? So you have to think about it as separate compartments. How big or how many compartments can the medication go into? And the more the medication compartments can go into, the bigger the volume distribution is. Now there is a concept of, as the medication begins to be cleared, you can look at it as what's called elimination half-times. And elimination half-times are great if you're giving a medication that uses what's called a linear correlation, and it's insensitive to how much time the medication's been given. And elimination half-times for us is very much a problem, okay? Because our medications tend to accumulate over time. So because of that, elimination half-times are a nice theoretical model, but clinically they're not very useful for us. Instead, we use something else called a context-sensitive half-time. And that's one thing that you really have to understand. Well, if I deliver an anesthetic, like sevoflurane, or let's say isoflurane, okay? And this is a classic way of understanding this. We used to put people to sleep for up to 24 hours for limb reimplantation, okay? And I had started the case around 7 o'clock in the morning, and by the afternoon I was down to around 1% isoflurane, and the patient was stable. I had reduced it from 1.5 isoflurane down to 1 by the time I left, and by the time I came back the next morning, it's at 5:30 in the morning and took over the case, the guy had left it at 1% all night. Okay? Well, the person that took over the case didn't understand that every so many hours you need to reduce the medication because it begins to accumulate. It begins to accumulate in the fat. So when I asked the surgeons, how far out are you? And they said, well, I'm about an hour away from being done. I just took the isoflurane and shut it off. I still had an hour to go. And the other person that was with me said to me, the case has still got to operate. I said, trust me, it's not going anywhere. Okay? If you want to think about it another way, the compartments act as vaporizers. Okay? Just like we were delivering inhalational agents through a vaporizer, the tissue becomes a vaporizer after a certain amount of time. It fills with the gas just like a vaporizer now does. Okay? As soon as you shut off the main vaporizer coming into the patient through the lungs, the other vaporizer opens and starts filling up the blood content with the gas and keeps the person asleep. And it took 55 minutes before the person came down to levels where the guy even started moving. Okay? The surgeon was done in 45 minutes, so we only had to wait 10 minutes. Had we not done that, we would have been sitting there for 55 minutes to an hour after the surgery was done to wake this person up. Okay? So that's why you have to have the concept of what's called context-sensitive half-time. That concept is basically applying the concept of how long the medication is on board for then to understand how long it's going to take the medication to come off. There's also another thing that we'll talk about, which is effect site equilibration times, and then we'll also talk about recovery time. When you look at pharmacokinetics, again, it's a study of what the body does to the drug. Okay? And quantitatively, you can show how the medication is working based on these graphical representations. It'll tell you how much absorption, distribution, metabolism, and excretion is taking place. When you look at this graph, this is an intravenous dose of a bolus dose of propofol. You can see as soon as you inject it intravenously, it rapidly increases in plasma concentrations within around 30 to 45 seconds, which is what you expect when you inject something through the IV. And it hits its peak plasma concentration at that point. Now, after that, the medication begins to move into different tissues. Okay, so now the medication is sort of floating in the bloodstream, and as it gets to target tissue, which is, in this case, a vessel-rich group, the brain, the heart, and the kidneys, the medication begins to be moved into those compartments. So as a consequence, you see the plasma concentration begin to rapidly fall off. This is simply from the process of distribution. It's distributing into the tissue. And then you can see the line down here that the medication is beginning to slow down in its fall, And a lot of this is due to now elimination and metabolism, the last component. So you can break it up into two parts. The amount of absorption that you're taking place, your maximum absorption, followed by your immediate distribution, followed by your elimination and metabolism, which is your clearance. Now, the good thing about our medications is that we bypass a lot of the problems. We take absorption and eliminate the problem by going intravenous. But still, you have to have that concept in your mind that you're not putting it directly into the aorta, so it's not pumping it directly to the heart, directly into the brain. It's actually pumping it directly into the venous capacitance systems. Okay? So when you're giving intravenous drug, it comes back to the right atrium, right ventricle, eventually goes to the lung, and some of the medications can actually be eliminated by the lung considerably. Okay? Now, where do you see this? Well, epinephrine is one of those drugs. When you give epinephrine IV to somebody, almost 67 to 70% of what you inject will be broken down by the lung before it gets to systemic circulation. I personally have seen this because one day I had a patient code on me, and the patient had no IV access, and we were really desperate, so I threw in a subclavian line in the patient. And now they were doing CPR during this whole time. Everybody had been trying everywhere else. The guy was dry as a popcorn. So I got it in. I felt real proud of myself. And then we took the IV epinephrine, gave 1 milligram, and we gave it in one shot. Man, this guy came off the bed. It was impressive. It was like, I've never seen epinephrine ever work like that. And the guy turned around and woke right back up. I was going, wow, that was magical how fast that epinephrine worked. And pretty soon I'm looking at my central line, and blood's starting to squirt back up it. Where did I put it? Right, I put it in the subclavian artery, and it actually was in the aorta. That's why it works so fast. It got 60-70% of its distribution. Its elimination was immediately not a problem anymore. So you have to keep that in consideration. Okay? Why is that sort of important? If you put on somebody on the bypass machine and you don't have really a lung tissue to absorb medications, you might have a much predominant, more effect because of that as well. If you look at the circulation, then it goes into the 3 vessel-rich groups, which is the distribution part of it. And the ones that you need to think about for vessel-rich groups is the brain, the heart, and the kidney. The secondary group, which is we call the medium-rich group, okay, is the muscles, liver, okay, and then your very low velocity group is tends to be your skin, and it tends to also be your fat. So ultimately, the medication gets metabolized or cleared. Okay, metabolism is very important. We'll discuss that in a little bit. It's how the medication is converted into either something that's more water soluble or something that can be excreted via the biliary tract. Okay, if the medication is converted into a more soluble agent, then it can be eliminated by the kidney. Okay, the kidney cannot get rid of anything that's lipid soluble. It'll filter easily, but it'll be reabsorbed almost immediately. So for that reason, many medications that are lipid soluble must be broken down by the liver. And we're going to talk about how the liver does that by biotransformation reactions. When you're looking at absorption, absorption is one of those concepts that's based on the concept of passive movement through a semi-permeable membrane, which again we're talking about diffusion. Okay? So diffusion is dependent on concentration gradients. It's also dependent on the solubility of the agent. And by solubility, it means how well will the medication cross the blood-brain barrier. How soluble is the medication? Then you have to also think about the surface area, the exposure for that medication, thickness of the membrane. And also very important are local conditions, which is the most important is blood supply. And we're going to talk about that and when we talk about local anesthetics later on, about how blood supply affects how the local anesthetic is absorbed into the system. Okay? The areas that have very high blood supply, like the pleural area, if you inject medication into that, you get a very rapid reuptake, which means that you have toxicity, but also the duration of the effect is diminished, because that's where you're trying to inject it in the site where you want the effect to take place. Versus other areas which have lower blood supplies, like the skin, the medication works for a very long period of time. Absorption effects basically affect how fast the medication is taken up, and then it's also dependent on the duration of its action, especially if it's a local infiltration that you want to keep the medication there. That's one of the reasons that's where you sometimes will add epinephrine, especially with areas that have high blood supply, to squeeze the vasculature and hopefully decrease the reuptake of that medication or the uptake of the medication so it keeps its function. That's why you see dentists inject epinephrine with their local anesthetic, simply to vasoconstrict the mucosa, give them better surgical field work, but also to decrease the absorption of the medication and give them a greater duration of effect. If you look at pharmacokinetics for absorption, it can be described based on where it's going in, as either enteral or parenteral. Enteral means that it normally follows the normal GI tract somehow. Okay? Things that you can use is a sublingual route. We use this extensively for like nitroglycerin. The benefit of you going sublingual is that you bypass the first pass effect, which means that you bypass the liver's metabolism before the medication gets on board. The way the medication gets on board sublingually is that you absorb it through the veins in your head, and then your mouth, and then it goes down into the internal jugular vein and returns to the heart immediately into the superior vena cava. So it bypasses the liver as a consequence. Now, one of the things that you have to understand, though, is that the quality of the absorption depends on the activity of the medication. A medication is only as good as its bioavailability is. And one of the things that you have to always think of when if you have to give somebody nitroglycerin, you have to ask the patient, is it burning in your mouth? Okay? If they don't tell you that it's burning in their mouth, the nitroglycerin is no good. Nitroglycerin is usually put into an amber bottle because it breaks down with sunlight. And a lot of people in Florida carry these things around in their pocket, and then you'll tell the patient in the ER, do you have your nitroglycerin with you? And says, yeah, let me pull mine out. And they put it underneath their tongue, and nothing happens. But there's no improvement. Well, the reason there's no improvement is because that nitroglycerin is no good. Okay? So you always have to ask that question, is it burning underneath your tongue if you're using that medication? As for GI-wise, when you give something PO, when it gets into the stomach, you can get acid changes that affect the absorption. And also, once it does get absorbed through the GI tract, usually through the small intestine, it will immediately go into the portal circulation, which then exposes the medication to a hepatic metabolism before it gets into your inferior vena cava and eventually into your systemic circulation. The other area where you actually can use the enteral system to actually bypass the liver from doing anything is by using the rectal route. We actually do that quite a bit with little kids when we want to sedate them. This used to be done a lot in the old days, but we've moved away from it with the newer anesthetic agents that we have. You can actually put a little Foley catheter in the kid's rectum, and then you inject methotrexate or Brevitol into the kid that way. And unfortunately, most people didn't understand this, that you only had to put the Foley catheter in just a little bit. People would get freaking out, and they put the catheter in too far, and when they injected the medication, nothing would happen. And they would be like, well, I see the medication doesn't work. This is a stupid way of doing it. I said, no, well, what you're doing is you're putting it too far up. You need to just use what's called the middle and inferior rectal veins for absorption, and these medications immediately go into the inferior vena cava and bypass the liver, and then you subsequently get the effect very quickly. And it's actually very effective. To all these problems, of course, this doesn't affect bioavailability. So what we try to do is we consider other routes that are more consistent to get the medication in. We can use cutaneous, subcutaneous, IM injections. IV is still by far the preferable route, and you can also use intraperitoneal, intrathecal, and inhalational is the other preferable route that we use. These are something that you should just read on your own time. I'm not going to go into that. There is some benefits and limitations to all these medications, to any of these routes, I'm sorry. So just make sure that you go over this really quick on your own. So just read it over it. I'm going to go through it by giving these slides. If you use the oral transmucosal absorption, it has a very rapid onset because of very high blood supply to the head. Actually, it's something that's pretty consistent throughout. If you don't have a good blood supply to the face and the mouth, then usually means you're not getting good blood supply to the brain, which is not a good thing. The good thing about it is that when you give it transmucosal in this area is that you bypass the first pass effect because it directly goes into the superior vena cava. The first pass effect is actually decreases bioavailability tremendously, and because the liver metabolizes many medications before it gets systemic. So anything that you give orally goes in through the intestinal tract, gets absorbed to the portal vein, broken down by the liver before it even reaches into the systemic circulation. And it really depends on different levels of liver activity. And that's one of the real problems with bioavailability, that you have to take the population you're dealing with and understand what they do. We had a classic example of this so many years back where they were testing a medication in Utah. And in Utah, people don't drink caffeine. They tend to stay away from alcohol. And they don't do as many drugs as other people do. So as a consequence, when they studied the medications, their dosing was much, much less. Then they came to areas, in this case, this was Tampa, where it was being studied. We were doing IV medications at that point, which was fentanyl. It was kind of away from the liver, but the liver still was metabolizing the fentanyl. And they told us that they would use 10 mics of fentanyl and they would have perfect effect. Well, we got it. We were using 10 mics of fentanyl, and the people were looking at us like, huh? What's this for? And we just kept giving it, and eventually we got up to 100 mics on every single one of our patients, okay, before we got the effect that the actual article was describing. And it was a great drug, but we called the investigator. The investigator said, you're going to kill people. We give 100 mics, these people are unconscious and they don't wake up for hours. I said, okay, well, why don't you come over here to Tampa? So he flew all the way over, saw what we were doing. He was kind of scratching his head. Maybe there's a problem with bioavailability, if there's something wrong with the medication, the way it was made up. So they took the whole batch away from us, which was an experimental batch, and they reanalyzed it, made sure there was the right concentration. Sure enough, it was the right concentration. And they said, you must have different patients. And said, yeah, well, all our patients tend to be drug addicts. They tend to do oxycodone. They tend to be doing lots of caffeine, which we figured out that it was simply a different population. So they had to change it. Okay, the same thing happened when they gave Versed. When Versed initially came out, the actual recommended dosage for it was 5 milligrams IV. And a lot of people arrested. Okay, and especially old people arrested on us. Okay, so you got to be very careful. 2 milligrams is enough for most people. If 1 milligram can actually be sufficient, and if you're talking about 70 or 80-year-olds. So always take that into consideration. Remember the patients you're taking care of. And your practice has to change based on that. This is the rectal administration. This is the inferior and middle hemorrhoidal veins. These have tremendous amounts of capacitance to absorb medication. And these will bypass the first pass effect completely. The superior hemorrhoidal vein will go right directly into into portal circulation. So that's why if you put the catheter in too far, it doesn't work. Okay, the liver will break down the methylhexatol very easily, and will basically not give enough bioavailability for the brain to be knocked out. As for transdermal absorption, we're using this more and more, especially like things like scopolamine, and it does matter where you put it. Because good transdermal medication has some limitations. It has to be able to be combined with water and lipid solubility. It has to have a molecular weight less than 1,000 usually. It has to have the pH between 5 to 9, because if you use too acidic pH or too alkaline of a pH, it will burn the skin. It really has to have no histamine release, because people will start scratching on it and will cause problems. They'll get absorption variably through their fingers and stuff like that. When you use this stuff as a practitioner, make sure that you're wearing gloves when you apply this to somebody. Because if you're taking scopolamine patch and you leave it on your fingers, and then you put it in your mouth, you're going like, whoa, what happened? You'll feel like you're drugged out. So be very careful with these medications that you don't touch them, because you have variable absorption in you as well. It's really this absorption, this little patch, is dependent on the stratum corneum thickness. So areas that have a lot of thickness, it's going to be less. It's going to work less. So somebody who has a lot of sunburn, a lot of injury to his neck, when you put it up here, it's not going to work as well as you want. Okay? Heat is also very important. The higher the heat, the more absorption you have, because you basically increase particle velocity. So you're able to do this. The way we would actually get some medications like the local anesthetic EMLA. How many people know what EMLA is? Okay, EMLA is a local anesthetic we would do as a paste that we put on kids to numb up their skin instead of using a needle. Okay? The way it's put on is you put the EMLA cream on the skin, and then you put a Tegaderm patch over the top of it. Okay? And then you'd sit there and wait for 45 minutes before the local anesthetic would work. That's way too long. And most kids are going to be going, you know, they want it off, okay? So one of the tricks that we found that actually works really well is take a hot blanket and wrap it around their hand. And, you know, it really warms up the hand, which kind of makes them feel better. And the other thing it does is it takes the medication, heats it, and makes it transfer even faster. The other thing that I've also seen works is they would take ultrasound probes and put it directly on top of it, a flat ultrasound probe, and they would emit ultrasound frequency, which then agitates the particles and makes them enter in more rapidly as well. So there's some pretty nifty tricks out there that people use. Okay. So the typical examples where we use transdermal absorption is scopolamine. Scopolamine's been really catching on recently to decrease PONV, which is post-op nausea and vomiting. We also see it being used a lot in fentanyl. I saw somebody come in the other day with about 10 fentanyl patches all over their body. I'm going like, what are you doing? And she said, well, they kept telling me, says, keep adding it till the pain goes away. And I said, I think that was your oral medication. I don't think that was your fentanyl patches. She had literally 10 of them all over her. It's like, oh my God, you're going to get overdosed and die here, you know? But she had so much tolerance that she tolerated it. But it's really not smart. Okay? Nitroglycerin, I'm not a real fan of giving nitroglycerin paste to anybody. I would rather give sublingual or IV. The reason I'm not a real fan of nitroglycerin paste, although I've done it for many times in my career, is that you get so much variable absorption that it's very unpredictable. I'd rather give it IV so I know exactly what I'm dosing and to get the effect that I want. And I always know nitroglycerin is working. You know why? A headache. All of you have heard it. I had this terrible headache. Can you stop this medication? You know. So sometimes they hurt more in their head than they hurt in their chest, and that way you know if you've cured them at that point. So now inhalational absorption is something that we're going to talk about a lot in the next 2 or 3 days, 2 or 3 sections, and then we're also going to get. I'm going to have Brian Mears and Dr. Cook come in one day and talk a little bit about what their experience is in the clinical area as well, to give them a slightly different feel for this lecture series as well. One person that actually is doing it in the standpoint of, like you guys, that's just graduating, and another person that has been doing it for 35, 40 years, and actually knows one of the men, and he was actually one of his, he was a fellow with Dr. Eager, which is a guy that develops desferrine in this country. So he does know quite a bit. What you're looking at for inhalational absorption is the concepts of how to get the medication in. The way we have to do that is by concentration gradients. So you have to get the gas all the way down to the alveoli, and eventually it has to penetrate into the blood. Now, what you'll read about in the textbooks is they'll say about the medication as being soluble, medium soluble to insoluble. That's our actual spectrum of our medications. What was used before the 1960s and before that, they were all highly soluble agents. Okay? Chloroform, ether were really, really good anesthetics. I still remember to this day, because I've went several times to the hospital when I was a little kid, I would walk in the hospital and I didn't like the way it smelled. It smelled odd to me. It smelled like very, I don't know, kind of a pungent, ethereal smell to it. And what it actually is that you're smelling, if you remember that, is you're actually smelling ether or chloroform that people were getting in those days. The actual patients were breathing the gas off, and you could actually smell it in the hospital. Okay? If you go into any modern hospital now, you don't smell that anymore, simply because the anesthetics that we use are medium solubility to insoluble, and the patients usually have it off their system very quickly before they even leave the recovery room to significant levels. But literally, in the old days, when they gave you chloroform and ether, it would come off your system for up to 24 hours, and you were grogged out for 2 to 3 days. And some people it took up to a week to wake up from the stuff because it's so soluble. Okay? Now, by soluble, it means that how is a gas able to penetrate into the bloodstream? The more soluble the agent, the bigger the volume of distribution is. Okay? Because it can penetrate many tissues. So you can see in this example, this is an insoluble agent that has to go into a volume distribution that's actually fairly small. So because of that, it reaches equilibration very quickly. So one of the benefits of having an insoluble agent that actually works is that it works very, very fast. Okay? The other benefit of it is, because it has a low volume distribution, is that you have a small little vaporizer on the other side of it when you shut it off. So it actually comes off quickly as well. So you really want an insoluble agent that works. Okay? Versus if you use a soluble agent, which is in the bottom here, you can see that the volume distribution is much bigger. And initially, the actual vaporizer is actually fairly small, but you give this time, this compartment and the other compartment, which is not shown here, which is the fat compartment, will eventually fill up with tremendous amounts of gas, and then it will act as a very slow vaporizer, keeping you asleep for long periods of time. Okay, so this is a visual representation of differences in volume distribution simply from differences in solubility of the agent that you use. Okay? Now, we'll talk initially about IV medications, and then we'll talk about, in the last hour this week, today, is going to be on inhalational agents. Hopefully I'll get into MAC today, but I think I'm not going to be able to because this is pretty heavy stuff. So we'll talk about MAC next week most likely. Anyways, IV absorption is direct access to the blood volume. So, but once you give medication, you got to think about it. Even blood has its own compartments. Okay? Blood's not straightforward in the sense that it has cells, it has proteins, it has just plasma, but it also has lipids in it. So that makes blood actually many different little compartments. And if you inject a medication that only binds to proteins, that's fine. If the medication is only dissolved into plasma, then actually that's only 60% of the volume, okay, which is not all that much. So the volume distribution is lower. And if you have something that basically goes everywhere and goes into the red blood cell, then you have a much higher volume distribution. So, and there's different medications that go into different areas. Okay? So, but there's different little compartments because of these different areas of proteins, lipids, and actual cells like red blood cells. Now, once the medication gets into you and it's absorbed, it then is delivered from the intravascular tissue to the cellular compartment. That is called distribution. Okay? What affects distribution is blood flow, and that's a big part of it, protein binding, molecular size, ionization, and lipid solubility. And we're going to talk about each one of these concepts. This distribution can be described by either a one-compartment model, which is pretty much useless for what we do. Instead, we use a two or more compartment model, and that's one I'm going to concentrate more on because that's really what applies to us in anesthesia. In the two-compartment model, the medication can be broken down into distributed zones, or called groups: the vessel-rich group, the medium-rich group, and the vessel-poor group. Now, one of the things that I also want you to sort of think is a lot of people sort of have problems with distribution. Okay, they have a hard time, like, how does this stuff really work? I mean, how is it actually getting to the tissue? The analogy I sort of want to make is, I use this all the time in clinical and in my own thinking, is that I think of it as a train with a bunch of freight cars. Okay? Now, what determines where the train's going to go is going to be the train tracks. So the more track that you have to one area, the more the actual train is going to deliver stuff there. Okay? So if you have a vessel-rich group, it's like having train tracks that are going into a major city. So you have lots of trains going in that area. Okay? So you can have more delivery of medication to that area. Okay? Now, how fast the train is going, of course, increases the velocity of delivery, which in this case, instead of just thinking of a train, how fast it's going is cardiac output. So the more rapid the cardiac output, the more rapid the distribution is going to be. Okay? Now, the other thing I look at it is I look at the boxcars. The boxcars are unique in the sense that they have doors in them, okay? And these doors can depend on if they're open or closed. If the doors are open, the contents within the freight car, which I'll call boxes, will be easily distributed to tissue a lot more easily. If I close the doors, then the boxes don't leave. And if I partially open them, then I can get some amount of the boxes out, but it's limited. And what determines the freight door from either opening or closing can be two concepts. One is protein binding, If you make something very highly protein bound, the door is closed. It stays inside the freight car. Okay, if you make it a low protein binding, then it's easier to, the doors are open and allows the medication out. The other thing that also helps keep the doors closed is a concept of ionization. So it's two concepts, protein binding, and the second concept is ionization. If you have something ionized, charged, then that medication does not want to leave the boxcar. It wants to stay right where it's at. It's happy. If you unionize it, then it'll transfer across and be delivered. Okay? Now, the other thing that's important is, if you think about it in the sense of the freight, what's the box size? Okay? The bigger the box, the bigger it's going to weigh most of the time, right? So it's more difficult to move around. So the box size, or what we call the molecular weight, is also going to affect your distribution. The larger the molecule, the less likely or more difficult it is to push out of the freight car. And the last concept is to how fast you unload it. That has to do with how many workers you have available to transfer the boxes out of the freight car out. And the way I look at that is lipid solubility. If I have high lipid solubility, it means I have a lot of workers pulling the stuff out. It's much more quicker to take place. Okay, so break it down like that. It will stick in your mind better, and hopefully that'll help you understand this material better. Now, the one compartment model is very simple. It literally indicates that as soon as you inject the medication, it distributes evenly all over the body. That never happens. Okay? But if you want to use that model, it's actually a very simple model which takes the concentration of the medication over time, and it falls in this kind of a very gradual curve. When you convert it into a log concentration over time, it becomes linear. And for that reason, it's a great model to sort of describe to people how things change over time inside the patient. Now, this does not take into consideration that blood's going into different compartments and different percentages. So in that sense, it's not very effective for us clinically. The two compartment model is what we use, and we can break it down into separate three curves here. Okay? You can still see this is a plasma concentration curve you see here. That's your plasma concentration curve there. And so that looks very similar to this curve up here, which is a one compartment model. But the explanation of this is very different for this one. Okay? This one explains it by using what we call compartments. Okay? And you'll see on this line, this is the green solid line is your plasma concentration line. That's the medication after it's been injected. This is the maximal plasma concentration level. Then it begins to fall rapidly. The reason it's falling rapidly is because the medication is distributing to the vessel-rich groups. So it's going into the brain, the heart, and the kidneys. Okay? And you can see the medication spikes to its highest level in the vessel-rich groups. And at that point, other compartments start to fill. But you can see that they're filling at different rates. The vessel-rich group has a much faster slope of ascent on this concentration, which means that it's the first compartment that's taking up most of the medication. Eventually, you'll see the muscle group, or what's called the medium-rich group, begin to fill next. Okay, it does it more gradually, but eventually the vessel-rich group is actually beginning to fall as the muscle group is still increasing. And you have to ask yourself, why is it doing that? Okay? And the answer to that is that it's redistributing. That's what they mean by the word redistribution. It's going from the vessel-rich group, and it's redistributing to the next lowest compartment. Eventually, all the medication that you have will be left for residual in your fat group. The muscle group and the vessel-rich group will be completely empty by about 120 minutes over here, okay? And what you'll still have medication still be available in the fat group. Okay? But is it active? It depends. Most of the time for our anesthetic agents, when it deposits into the fat, at that point it's inactive. It never comes back to giving you a higher concentration enough that makes you knock out, right? Makes you go down again. But the downside to it is that all that medication that's in the fat, it has to do what? It's not going to sit there forever, right? It's going to leak continuously back into your bloodstream, and your body's going to have to do what with it? Metabolize it. It has to eliminate it. And in some people, the metabolism byproducts makes them sick. Okay? Some people, they have different enzymes in their body, so when they break these stuff down, it doesn't break it down into something that's totally inactive, but it's something that's partially active and actually may be toxic to them. And that's why you see some people retching for 6 to 8 hours after surgery. Okay? It's simply from the metabolism of these byproducts they just cannot tolerate. Now, the volume distribution is something that's important because it gives you an idea of how many different compartments you can fill. The actual drug lipid solubility is actually the most important in the sense of how many compartments you can bind. And also binding the plasma proteins, remember, that limits your volume distribution, molecular size, and ionization. Those are all part of the distribution model. But the nice thing about volume distribution is able to allows you to estimate the amount of drug in the body, the peak serum levels that you can expect, and also the rapidity of your clearance. The way we actually figure out the volume distribution is we take a plasma elimination curve, and we see it and we break it down into different components. The first descent slope is what we call the alpha distribution phase. So that has to do with medication going into the tissue. And then you see this next curve that flattens out. Okay? That's called the beta curve or the elimination curve. That has to do with both metabolism and elimination. Okay? And that becomes linear. Okay? It falls down linear like this. Okay? Now what we do with this is we figure out the volume distribution by taking this line and creating this light blue line which goes all the way back to your plasma concentration curve, and that becomes point B. Okay? So it's the actual volume distribution is the maximum serum concentration over B. Okay? Now, well, how does that work? Let's say a medication is very lipid soluble, okay? Which means that it's going to penetrate into the tissue very, very fast. Well, if that were to happen, then this distribution would basically fall very quickly. I'm doing the other one first, okay? This one is a person who has a low lipid solubility. And this individual, in this curve, this individual has a situation where the medication is staying intravascular. Okay? It has high protein binding or low lipid solubility. Okay? And as a consequence, it doesn't distribute as quickly, but now there's more of the medication to do what? It has to be broken down in the plasma. Okay? So this one will have a lower volume distribution. The actual B value is actually going up. So if you increase the B on this one, your volume distribution falls. On the other hand, if you make something very lipid soluble, which is the next graph, you see the graph descends very rapidly like this. Okay? This tells you that you have very high lipid solubility, or you may actually have low protein binding as well. And that gives you a very nice increase in volume distribution. This is what the book was trying to explain, but did it very poorly. So I wanted to make sure that you understood how they actually come up with the volume distribution. Okay? Now, if you look at the volume distribution, it has to do with lipid solubility. This is where the book was trying to get you to understand it, and I wanted to show you graphically to you. Low lipid solubility and high plasma protein binding leads to a high concentration in the plasma, which was that upper curve. Gives you a low volume distribution. A clear example of this is the non-depolarizing muscle relaxants. Normally, they have a low volume distribution. On the other hand, the ones that have high lipid solubility and low protein binding are things like propofol. Okay? So they have low plasma concentrations very quickly, and they have an increasing volume distribution because they're so lipid soluble. Protein binding is also a big factor because high protein binding limits the drug distribution to leave the plasma. And as a consequence, the volume distribution is inversely proportional to protein binding, which means the higher the protein binding, the lower the volume distribution, versus the lower the protein binding, the higher the volume distribution is. The proteins in your plasma, of course, are albumin, and you have to sort of think about this. Medications that are acidic are bound by albumin, And medications that are basic are bound to an acid. In this case, it's called alpha-1 acid glycoprotein. Okay? A goes with A, which is albumin goes with the acid. Okay? And alpha acid glycoprotein goes with the base. Okay? So how do you know that? Who cares, right? Well, medications can be broken down into two family groups, usually. They're either acids or bases. Okay? If you have medications that have acids, that are acids themselves, it'll actually be attached usually to a base to ionize them. Okay? And if on the other hand you have a base, it's usually attached to an acid. If you look at lidocaine, lidocaine's a local anesthetic. Is that an acid or a base? It's actually a base. Okay? And the way it's mixed up, and we'll talk about this in the next hour, I think, is on ionization, is that you have to charge that molecule so it doesn't stay, so it stays in solution. So the medication is usually that you add to it is hydrochloric acid. And you'll see that on your vial. I'll show you that in a picture in a minute. Protein concentration can vary in different disease states as well. So you have somebody who's severely malnourished and stuff, you can have some significant problems. And clearances is limited by high protein bound medications. Okay, I got 5 more minutes. Protein binding, high protein bind are things that small changes can radically affect it, which is a problem. So medications that are highly protein bound, if you reduce the amount of protein binding, you can have drastic effects. And that doesn't kind of make sense when you think about it, right? I mean, you think like, why? Something's highly protein bound, it's a little bit of change in protein. Why would it make such a big difference? So it's a mathematical construct, okay? So you sort of have to look at it mathematically. Most of us, when you look at math, we look at numbers and things become abstract. But in this job, you've got to bring it down to the level, what does it really mean to me? How do I use this concept? So what I've done it for you is I've drawn it for you. Okay? This is an agent on the left-hand side, I mean, right-hand side of your screen, that has a very high protein binding. Okay? Because of it, only 2% of the medication is actually transferring across, because the other 98% is being held. So if you put this concept as 100 particles on one side, only 2 particles are able to transfer across at any one time. Okay? But still, with 2 particles crossing over, it still has efficiency. In other words, it's very potent. Okay? So that medication, if it has any effect at all, it must be potent. Okay? Otherwise, you'd be wasting your time. If it's 98% bound and only 2% crosses, and it's not strong, it's going to sit there and do nothing to you. Okay? But if you have something that's actually doing something, that means it's very potent. Example of that is warfarin. Warfarin is actually a very potent drug. Okay? Now, if you change the protein binding just by reducing it by 2%, which is not very much, okay? So you go from 98% to 96% bound, how does that change anything? Well, instead of allowing 2 particles to cross now, you're now allowing 4 particles to cross over. That's not that much difference when you look at it as a number, but when you look at it as a percentage, it's huge. It's a 100% increase in total particle crossover. And it means that the effect is doubled. Okay? So you can poison somebody really easily by changing their protein binding concentrations. Does that make more sense? Because the book was kind of unclear. Okay? Now, as to another situation, if you're low protein binding and you change the protein binding, really nothing really happens. Okay? It's really insignificant, the effect. And let's give you the mathematical model. This one is, I've taken a situation with something that's 70% bound. So 30 particles come across. Okay? And now we're going to drop it down to 68%. Okay? It's a 2% difference, which means that only 2 more particles come across. So now it's up to only 32 particles. When you do the actual math, it's actually an increase of only 7%. So you see, when you go to low protein binding, the effect of slight changes in protein binding really does not make a difference clinically. It's a high protein binding medication that you have to worry about. So that means if you read that a medication is highly protein bound, you have to think of toxicity in the back of your mind very quickly. What happens if I give this to a person who has low albumin levels? Let's say the person has cancer. and I give them a medication that normally would be pretty potent but doesn't give a problem to somebody. But in this individual, you give them the same medication, the same dose, you're going to find out that that person just falls apart on you. And you have to keep that in mind. Some of you will end up working in cancer research centers or in areas where they do a lot of cancer surgeries. In those cases, you've got to keep the back of your mind what the high protein bound drugs that you're giving. Yes? What's that? Yeah, there is, but it's one of those pharmacokinetic models that is actually difficult to find. And so what I'd recommend you do is you go look up an individual drug for anesthesia that has high protein binding. Most of the medications now are not so highly protein bound what we're giving, so it's not really much an issue. But some of the medications that they ask you to administer during the procedure, like antibiotics and stuff like that, may have higher protein binding, and then you have to take into consideration. And at that point, I would call the pharmacy and ask them to put the model into the computer, and that'll help you that way. Okay, because it's a little bit more complicated than I'm showing you. It's just you have to consider it. So then you can get the pharmacist to help you. There is a place for everybody in life. Pharmacists do very important jobs. Okay, you know, they know stuff that we don't necessarily know. But at the same time, we have to take care of the patients, and we're the ones that are at the end of applying the medication. So we have experience, which is a big difference at times. Theoretical and experience are two different things, as you'll find out soon enough. Now, let's go on to talk about this concept, which is the two-compartment model, or the two or more compartment model. When you give the medication directly intravenously, it goes into the central compartment. The central compartment then goes from there into the different peripheral compartments. And each one of these compartments has a K value, which means how fast the medication goes into it. The higher the K value, the faster that medication will distribute to that tissue. Okay? So K values are kind of important in understanding how fast the medication goes in the tissue, and then comes out eventually back to the central compartment, which eventually is cleared. The KE stands for the clearance rate of the medication, or elimination rate of that medication. When you look at the vessel-rich group, the first pass with IV administration goes to the heart. Lungs can actually take up some of the medication up to 65%, especially if they're lipophilic drugs. Brain and kidney will also be involved in the first pass with a high extraction rate. And by the time that goes around to the second pass, the liver now is beginning to metabolize the medication, so you see a rapid decrease in medication as a consequence. The central compartment is, you can see that it uptakes a considerable amount in the brain and the viscera. You can see in this red line. This is what I was showing you before, how the medication goes out of the plasma directly into the vessel-rich group, and then eventually goes into lean, and eventually it goes into the fat group. Ultimately, the last place of repository of medication is going to be in the fat group until it begins to be eliminated and metabolized at that point. Redistribution is that first part where the medication leaves the brain and the other organs and redistributes to the lean and fat body tissue. If you're looking at medications that are affecting the brain, you want to have a medication that goes on and then comes off fairly quickly, so the person emerges from the anesthetic in a very reliable manner. Okay? And we do this all the time. Now, you have to take into consideration, too, that though after a while, if you keep giving the medication, the other compartments start getting saturated, and guess what? The medication then can't redistribute. Example of that would be sodium pentothal. So thiopental, when we used to give it to people, we would just give it as a one-time dose. But sometimes we were asked to do it as a continuous drip on patients. Well, during the continuous drip, what would happen is the medications would begin to accumulate in the fat and the lean body tissue, and then when you stop the medication, it just wouldn't come off. The person would stay asleep for hours. So determination of action really is determined by how much saturation you have in the other tissues as well. If you increase the dosage or give repeated doses, you actually may get saturation of other sites, leading to the prolongation of the effect. Now, the rate and capacity of tissue uptake of the drugs is determined by blood flow, concentration gradient, blood-brain barrier, and things like physiochemical properties of the drug, such as ionization, lipid solubility, and protein binding. The determinants of capacity of tissue to store the drug is also important in the sense that the solubility of the agent, how well it can penetrate into the tissue, how big the tissue mass is. So if you have more mass in one compartment than you should have, then you have a bigger volume distribution for that drug. So people that are morbidly obese have a higher tissue mass of fat, and as a consequence, if they get a medication that's highly soluble, it tends to penetrate into that fat and keep them basically effectively asleep by that medication for longer periods of time. And that could be a problem, especially if you have low functional residual capacity. And you don't want to impair the respiratory drive, but in these people, they have a higher complication rate with the more soluble volatile anesthetics. How well the medication will bind to macromolecules and the pH of the tissue can also be important. Where the pH of the tissue can become an issue is like, say, you inject local anesthetics. If you're injecting local anesthetics in somebody who is very acidic, the medication stays ionized and as a consequence does not work. So people that have infections, that have low pHs in their tissue, the medication doesn't work. If the person is in chronic renal failure and their whole body is acidotic, the medication again doesn't work. If some people that actually have very off diets that are different because of, they prefer or choose to be eating certain different substances, then their pH can either be high or low compared to the norm, and as a consequence, medications will work differently on them from that issue as well. Now, what exactly is ionization? Basically, our molecules that we use in medicine tend to be charged or uncharged. Okay? The charged medications, unfortunately, have poor bioavailability. They do not work well, in the sense that they don't cross the blood-brain barrier. They don't cross into tissue very well. So in other words, they become ineffective. But on the other hand, if you make them unionized, if you change them from a charged to an unionized state, a lot of the medications will then transfer. They will get across the membrane rather easily. So one of the things that we do want to do is we want to make the medication into an unionized form when we administer it to the patient. The downside to it is that as soon as you make something unionized, you make it not soluble. It tends to want to crystallize and fall out of solution. Okay? So many medications that we use are usually put into a state of charge in the medication vial. Okay? That way they stay in suspension. That's the reason that we do it. The downside to it is that when you inject it into the patient, the pH is usually out of the range of a normal human being, and it hurts. And it becomes very uncomfortable until the person basically takes that pH solution, makes it, neutralizes it, and then the medication actually begins to affect and to be absorbed. Okay? An example of that is, let's say we take sodium pentobarbital. Sodium pentobarbital is converted into pentobarbital, which is an unionized state. In the ionized state, it remains in filtrate and has reduced toxicity. But as soon as you make it unionized, it's reabsorbed and can penetrate very easily through lipid membranes and can have prolonged toxicity. Simply by changing the pH, you can shift the curve of where the actual molecule is going to be either an uncharged or a charged state. Now, one of the things that you do in chemistry is you talk a lot about pK. And I don't expect you to be chemists. That's one of my areas of interest when I was an undergraduate. That's what I graduated with, a chemistry degree. I look at it from the standpoint of that every molecule that I administer, I look at the pK value because it means a lot to me. Okay, pK value means that if my pK and my pH are the same, that 50% of that molecule is ionized and 50% of the molecule is unionized. Okay? If I shift the medication in each direction, if it's a pKb or pKa, I can make it either ionize more or unionized. Now, you can sit here and do all the calculations, do all the math. I don't expect you to do that. It's not part of this course. Instead, I just want you to get the concept. The concept is that the pK is a value where if you maintain that pH at the same number as a pK, 50% of the molecule is charged and 50% of the molecule is uncharged. Okay, so it forms an equilibrium. Now, if you take an unionized medication, the pharmacological effect will make it active. It tends to be lipid soluble. It crosses the blood-brain barrier rather easily. It also crosses the GI and the placenta easily because it's unionized. And it cannot be renally excreted. That's a real downside to it. Kidney can't get rid of it because it's lipid soluble. And the hepatic metabolism becomes clearly important in breaking this stuff down. If, on the other hand, your medication is ionized, it tends to be inactive. It tends to be water soluble. It does not cross the blood-brain barriers, which means it doesn't affect the brain. And renal excretion is actually pretty effective because the kidney can get rid of it and it doesn't get reabsorbed to the tubules. Hepatic metabolism usually is not an important factor in this situation. Now, you know that every single medication is in both these states. Okay, that's what you have to understand. Every medication that you tend to give is in both states. Now, you can shift the medication from one side to the other depending on what you're trying to do. If I were to give somebody Tylenol and I make them toxic, Tylenol is what? It's an acid. Okay? So if I want to get rid of it, okay, and I want to make it charged, what I would do is I would add a base to it. Okay? So if I was in a toxicology area where I was working in the emergency room and I heard somebody was Tylenol toxic, and I'd put an IV in them and immediately start a bicarb drip. Okay? The reason I'm making the bicarb drip is because I'm trying to push the molecule to stay in an ionized state. I want it to stay there so now the kidney can get rid of the stuff without the liver having to do it. Because when the liver metabolizes the unionized portion, the byproduct of it kills the liver. Okay, it actually is one of the most common causes of liver death in the United States is from Tylenol overdoses. And most people don't think of that. Okay? If you went to the pharmacies 10 years ago or 5 years ago, when you went and bought Tylenol, you'd be able to get it in 500 pills in this big, big thing. What was happening is little kids were sucking the whole thing down and then didn't tell mommy or daddy. They'd come in 3 or 4 days later and they would be in hepatic shock and die. So for that reason, now you can only buy, like I think 100 is the maximum you can buy. So it's a lot less. It's still in the toxic range, but it's not enough usually to kill you. Okay, it really hurt you, but it's not going to kill you, hopefully. Now, what determines the degree of ionization, again, is the pK and the pH of the surrounding tissue. Okay, if the pK and pK and the pH are identical, then you have 50% ionized, 50% unionized. Now, the question is, how do you know if the drug is acidic or a base? And what's really nice is that the manufacturers kind of help you. Okay, when you look at the way the medication is written out, okay, basic drugs are highly ionized in an acidic environment. Okay, and what you have is when they write it out for you, they write out the medication initially with the base first, followed by the acid following it. So you have lidocaine, which is a base, followed by hydrochloric acid. Haven't you ever wondered why the hydrochloric acid's there? I always did, and I was like, why did they add hydrochloric acid? I don't want anybody injecting me hydrochloric acid. I used to play with that stuff in chemistry, and it was very dangerous. Okay, and what the heck, they're adding it to my medications. And the reason they're adding it is they're taking a base and putting an acid and making it very highly ionized. Okay, and this is why when you give this medication IV, or not IV, but sub-Q, it really hurts. Okay, because you're injecting a highly acidic solution into that individual. Acidic drugs, on the other hand, are highly ionized in a basic environment. Okay? If the active moiety is a base, then the base will be listed first, which is what you see here. So that's always a helpful hint. If the active moiety is an acid, the acid will usually be listed last. They usually will put in the sodium, which is really sodium hydroxide, with thiopental. Okay, so that shows you the thiopental is actually an acid. So STP is the way we used to write as our nomenclature for sodium thiopental. Okay, S indicates that it's sodium. Thiopental is the acid component of it. It actually was kind of cool. When we used to give thiopental, we used to tell everybody one thing before the person went to sleep. Here comes your garlic pizza. It actually tastes like garlic. And patients would tell you that afterwards, that it tastes just like garlic. Because the medication is actually partly made from a byproduct of that. Ion trapping. This is an important concept because medications will not transfer into tissue if they're ionized. Okay? But as soon as they become unionized, which in this case is a base. So you got base with an acid, and it converts into a base that's now at no charge. That as soon as it becomes unionized, it transfers across the tissue. Once it gets into the tissue, then it transfers through the lipid membrane in its an unionized state. And then once it gets in here, it becomes ionized again. And the ionized component is actually what actually has the effect in this example. This is an example of local anesthetic like lidocaine. Lidocaine, when you inject it around the nerve, okay, gets immediately converted in the area around it based on the pH into an unionized state. That will then pass through the epineurium of the nerve, which will then form another concentration gradient, eventually leaving some form of unionized fraction, which then penetrates the lipid membrane. And then once it gets in here, it forms again your equilibration where it charges back up. And once it charges, then it actually goes into the rapid fast sodium channels, which knocks out the sodium channels and makes the nerve go to sleep. Okay? So if you want the medication to basically work faster, what would you do? You add a base. You simply add a base. Okay? So you add a little bit of bicarb to your solution, and it really makes the medication work faster. The problem with it is you can overdo it. Okay? A really very sensitive medication to changes in pH is bupivacaine. And the way you actually have to do it with bupivacaine, you usually draw it up in a 30 cc syringe, and then you take like 1 cc of bicarb into it, and that's it. That works great. But if you make the following mistake, you're going to find out what I'm talking about. You take your bicarb first and wash the syringe, right? Okay, that's just a little bit of bicarb, but you do that first. And then you drop the sodium bicarb. Then drop the bupivacaine. What will happen? It's the same 1 cc, right? But now you're dropping 1 cc to 1 cc of bupivacaine as it comes in. Immediately crystallizes. It just immediately crystallizes. And you never inject a crystallized solution to a patient. Okay, that's bad news. Okay? So have you ever seen a medication that's crystallized? You're done. That medication has to be thrown out, and you can't really reprocess it, because even if you think that there's no crystals in it, you might have microcrystals which could embolize in that individual. You don't want to do that. Okay? So that's called ion trapping. You want that effect in some situations to get your medication to cross and have the effect that you desire. Some of the ion trapping can also be important pharmacokinetically for elimination in final storage area. Fentanyl is a great example of this. Fentanyl is a very highly lipid-soluble agent. But the other thing that it is, it also redistributes very quickly. Where fentanyl goes is something that a lot of people don't understand, because they think that fentanyl goes into the fat. But actually, fentanyl gets trapped somewhere. Fentanyl, when you put it into a highly acidic environment, stays ionized, and it doesn't want to leave. So what tissue in your body would be highly acidic? Stomach. So guess where you find fentanyl in high concentrations after you administer it? In the stomach lining. Kind of cool. Okay? And that's why it's ion trapped in there. Okay? Now, is that really important? The answer is not normally, but if you have somebody who has a huge stomach and you start administering large doses of fentanyl to that individual, and I have seen people that have very big stomachs. You'd be surprised. You just don't know who has it. It could be genetic differences, and they will actually absorb a greater amount of the medication and seem that it's not working. So you keep adding more and more because it makes the volume distribution larger for that individual. But when you stop giving the medication, the saturation point is much higher, so that person then stays asleep for long periods of time, and it's kind of frustrating. And you don't understand why that happened. So fentanyl is one of those examples of ion trapping. Now, when you have the effect compartment, that's another concept. It's basically taking the central compartment concentration idea. It's not really reliable in all medications. The new model adds the effect compartment into the concept, which basically talks about receptor theory. Okay, where is it binding to have the effect? This model has been used more so in Europe than the United States, and one of the things that they're using more as a consequence to this is they're using what's called total intravenous concentration infusions, which is they actually targeting the actual infusion levels based on these compartment models, which is kind of neat. They're using computers to do that. Clearance is composed of metabolism or excretion. Most textbooks, I consider also redistribution to a certain degree as part of clearance, but the books want to make sure that you understood clearly that it's metabolism and excretion. Metabolism has to be organ-specific. It could be liver. The non-organic specific are the things like Hoffman elimination that are things that are breaking down like atracurium, cis-atracurium, or you have things like ester hydrolysizers like pseudocholinesterase that attack mivacurium and succinylcholine. Clearance is, if a drug infusion matches clearance, the drug basically concentration will be constant, which is what you want. Okay? If on the other hand your clearance exceeds your infusion rate, then the drug concentration eventually falls. And if your infusion rate exceeds your clearance, then the drug concentration will actually increase dramatically. And that's what happens in our management of most of our cases. Okay? Most of the time our infusion rate tends to exceed clearance rate of that medication, especially once it becomes absorbed into the secondary tissue. And that has to be taken into consideration. 11.5 times gives you an idea of how fast the clearance is taking place and gives you that slope over time. It gives you the idea of elimination. Now, elimination half-time is the slope of elimination from a log plasma concentration over time. It's basically the time necessary for the plasma concentration of a drug to decrease by 50% during the elimination phase after one dosing. Okay? And that's the limitation of this. It's only a one-time dosing. And what do we do with most of our medications? We're doing it either a continuous or as a multiple dose medication. So 11.5 time has a really significant problem with it. It's basically directly proportional to the volume distribution. The larger the elimination half time, the larger the volume distribution. And it's also inversely proportional to its clearance, which means that the larger the elimination half time, the less the clearance taking place. Elimination half time is really doesn't consider, and it's sort of independent of dosing of the drug administered, and because of that reason alone, it's not really reliable clinically. Basically, what you're looking at is that elimination half time is important in the sense of conceptually thinking of things. And we talk about volatile anesthetics, we'll sort of apply this rule so you begin to understand how gases come out. Okay? So you need to start thinking about it from this standpoint, and we'll talk about context-sensitive elimination half times, which is what I'm going to be teaching you next. But this first concept is thinking about how the medication is eliminated by 50%. If you look at, let's say we're using 100 milligrams of a certain drug, okay? So that's your peak effect. Let's say in this case it's 100. In the first time unit, how much time that it takes to break down 50% of the drug, okay? It goes from 100 to 50 milligrams, okay? So that's your first pass. Okay, and that takes so many minutes. Say it takes 10 minutes. 10 minutes from now, it's going to reduce that 50 milligrams by another 50%. But 50% of 50 is 25. So now you're going to lose 75% of the drug is going to be gone at that point, and now you're down to 25 milligrams. The next 10 minutes, you're going to get another 50% decrement. 50% of 25 is 12.5. So at that point, you'll be at 87.5% destruction of medication. And usually by that point, most people have no effect. Most times, most medications that we administer, within 3 half times, the medication is down to low enough concentrations that it really does not affect you to be knocking you out. Okay? By the 4th half time, which is another 10 minutes, you're going to break down 12.5 milligrams down to another 50%, so you're down to a 6.25, which ends up leaving you with 93.5% breakdown of medication. And by the 5th one, you're down to 96.9%. So you can see as the medication keeps clearing, it slows down. And that means the medication is taking a long time to get out of you. If you have a very soluble agent like ether, this would take not 10 minutes. Each one of these half times would be an hour and a half to 2 hours. So you can imagine how long it took to take this medication off you. You'd be asleep for days. Okay? So. Now, what we use next is a concept of what's called context-sensitive half times. And the reason we did this is because these elimination half times work great for drugs that are pretty much linear in correlation, and they only are binding to one tissue. But our drugs bind to many different tissue compartments, and they come off at variable K values out of each tissue. Some drugs are very lipid soluble, okay, which means that they stay in the fat for long periods of time. Example of that is like fentanyl. If you look at this in the context-sensitive time, the amount of the time for the plasma concentration to decrease by 50% after you discontinue a continuous infusion. For fentanyl, if you give it, let's say, under 25 minutes, it takes about basically 15 minutes for the medication to come off. But if you distribute them, if you give that medication more than 100 minutes, now it takes a half time of almost 60 minutes for that medication to drop by 50%. What it's basically telling you is that medication is going into fat and staying in really high concentrations. And when you shut it off, it just begins to ooze back into the bloodstream, and it takes a long time for you to break it down. Okay? The classic example that now we are using, okay, for some medication that doesn't really have that effect at all is remifentanil. Remifentanil stays in the bloodstream. It does not distribute into the tissue very much. Okay? So you can see this medication stays linear. It doesn't care how much time you administer that medication. So this actual medication works very well for the elimination of half times we were describing before. It works perfectly. It doesn't care how long you bid it on. For that reason, remifentanil is kind of useful. The downside of remifentanil is that when you shut it off, everybody's wide awake with no narcotic effect at all within 10 or 15 minutes. And that can be agonizingly painful for the patient. So then you got to sort of catch up by pushing fentanyl, and you're trying to offset one medication that's coming off while you're trying to introduce another one. And it can be a little bit tricky. Okay? The ones that are a little bit less soluble are sufentanil, but still gets accumulation. And then you have some medications like alfentanil that hit a plateau, which means they saturate certain tissues, and at that point they can't go anymore. So at that point, you're still going to get a fairly good elimination. But that saturation point is still at around 60 minutes for a half time, which is a pretty long time. Okay? Now, why don't we use this? And all of us have used fentanyl in the ICU, right? Have you ever been told, give the person a break for a day? The reason you're doing it is because alfentanil is just accumulating in the fat, and if you don't shut it off, it's going to keep accumulating. It goes to almost infinity. It just keeps going into tissue. So if you don't shut it off, then the person will stay asleep for a week. Okay, after you want it, when you want it to shut off. It would be preferable to use something like remifentanil in the ICU, okay, or even things like alfentanil, because it eventually does saturate into a constant sealing effect. But the downside to those medications is they're so expensive. They're just so much more expensive than fentanyl. The context-sensitive half-time takes into consideration what elimination half-time also does, which is distribution and metabolism. But the one that it doesn't in elimination half-time, which it does in context-sensitive, is duration. Duration of the continuous infusion. And that's ultimately what we want to know. There's no constant relationship to the drug's elimination half-time. That's reasonable. So with context-sensitive half-times, you can start predicting using specialized models as to how long it'll work, how have that effect. And you can put this into a computer, and as a consequence, then you can reliably understand what will happen when you stop the medication. Okay? What the new computers are showing is that they're showing you, if you stop the medication now, it'll take you this long to wake up the patient. So it always gives you a bar line where your landing place is going to be. Okay? If you know that the surgeon's going to be done in 30 minutes, and your slope of the line where it's going to descend and have awakening time at 30 minutes, you stop the medication at that point. Okay? Before, we would just go to the end and just shut off and go, pray, please, that it comes off. Okay? Or we're sitting there for a half an hour, and everybody's going like, what the heck's taking you so long? You know? And we go, well, the medication's not breaking down fast enough. And unfortunately, even the computer models don't perfectly work because they're taking a population to generate the data to make the prediction. But not everybody's the same, as you'll find out soon enough when you get to clinical. So time recovery tells you, it's a concept that tells you how fast the plasma concentration will reach awake states. If you look at this example, this person is running at 100 mics per kilo per minute of propofol. And when you stop the medication, they're wide awake in about 10 or 15 minutes. That's pretty consistent. But if you ran the patient up to 150 mics per kilograms per minute, and now you stop the medication, it still follows the same slope of descent, but it's taking you so much longer because you're getting too much medication. That's all they're trying to teach you here. So if you overdose the medication too much, the person is going to take longer to wake up. Duh, okay? But that's what they're trying to get you to understand. Okay? Effect equilibration site, or effect site equilibration, is a time for the dose medication to have effect. And different drugs have different times. It's important for logical timing of dosing. What that basically means, if I give you the medication IV, I should expect the medication to take so long to get there. And actually, if you see me, you'll see me look at my watch, or I'll usually have an internal clock that I should start running time in my head, okay, as I give a medication. And what I'm checking is, it should be, when I inject a medication, it should take 30 to 45 seconds for the medication to knock the person out. And that's a reliable number, because that's the circulation time between the vein the drug goes to the heart then's got to pump to the lungs, from out of the lungs goes into the left ventricle, and then pumps it to the brain. That should take about 30 to 40 seconds. If I see the effect hit the patient like that, then I've got a very high cardiac output. And that could be bad, because it could be that the person is dehydrated, could be in shock states that I really didn't know, and the person is compensating by increasing the cardiac output. On the other hand, if I don't see the effect happen in 30 to 40 seconds, I don't redose. I stop, because I know that the medication is still floating. And if I dose now, when I hit the second dose, the first dose will just be reaching by the time the first dose is getting in the bloodstream, and that person will all overdose the heck out of them, and they'll be in big trouble. You see this happen in labs all the time, where the medication like Versed is given to somebody, and then the effect's not get that, so you figure, I'm going to give another dose, and give another dose, and another dose, and pretty soon now the patient is apneic. Okay? I'll give you another example of effect site equilibration. It's always dependent on one important thing. It depends on the IV site. My wife had a procedure done a number of years ago, and when they were doing the procedure, they came out, and about 10 minutes into the procedure, and they looked at me and says, "Your wife does drugs." And I'm going, "What?" And I said, "Why do you say that?" He says, "I know that's not true, so why are you saying that?" "Well, the Versed not working." And I said, "Okay, can I step back with you?" And the guy goes, yeah, of course. So I step back in, look at the IV. I said, "It could be because you're subcutaneously injecting IM Versed." The dumbass. Okay? Okay? So I didn't add that part to it. But then they realized that their IV was no good. Okay? So effect site equilibration only takes place if you have an effective IV. So if you see a medication is not working, think back to the IV. Is it in? Okay? So my wife was really unhappy because she was out of it for about 3 days, because they gave her 15 milligrams of IV Versed, but it wasn't IV, it was also subcutaneously. So she was kind of gorked. Slow uptake. Okay? So people can do stupid things. Don't forget that part. Okay? So different drugs have different timing. Important for logical timing of medications, of course. If you understand effect site equilibration, you don't want to get it too fast, because then you get in trouble. Things with short effect equilibration times will have very rapid onsets. Things like remifentanil and propofol have very rapid onsets. But they also have very rapid offset as well many times. Drugs with long effect site equilibrations will have slow onsets, and you've got to be really, really careful with those medications not to redose them too early, because then you can get overdose on them very easily. A good example of that is midazolam. Even though it's water-soluble, it takes a little longer than you think to really get the medication on board. The other place where you can get in trouble is something like morphine. Morphine, you've got to give it every few minutes, okay, and wait, because it does take a little bit of time to equilibrate. I've seen people try to give too much morphine, and the person now is like very happy, but not breathing. Pharmacokinetics also looks into metabolism. It's basically chemical conversion or transformation of drugs into different compounds. The breakdown can lead to inactivation or activation. That's something that's important to understand. Some medications that we give actually are prodrugs that are inactive and then become converted into active drugs once it goes into the plasma and it gets metabolized. There's some plasma enzymes that also are important for our job, like pseudocholinesterase. There's also things like Hoffman elimination that don't really need any enzymes to have this reaction take place. And you have esterases as well. The liver is one of those clearly important organs for metabolism, as it uses a P450 system. The P450 system is found in other cells, in the body and other organs. So that's another thing to also take into consideration. Now, hepatic metabolism, this is actually in your certification exam, so that's why I try to go into this in a lot more detail. I don't want to bury you with too much detail because it's a little bit much, but you do have to know the difference between phase 1 and phase 2 reactions and what they do. And biotransformation basically indicates to you that you're biologically transforming a medication from one thing to another. Okay? The purpose of doing that is to make it usually from an insoluble, lipid-soluble agent to a soluble, water-soluble agent that the kidney can get rid of. Okay? The water-soluble agents, remember, have decreases of volume distribution, and they have increases of clearance in both the kidney and the liver, so that's why you're trying to do that. But not all biotransformation leads to inactivation. Some medications can actually lead you into trouble, okay? Like the conversion of meperidine, which is Demerol, in the liver to normoperidine. Normoperidine actually will cause seizures in people if you give enough high doses. So some times medications, the actual byproduct will get you into more trouble. The way you actually describe this is by hepatic clearance. And hepatic clearance has to do with hepatic blood flow times hepatic extraction rates. The hepatic blood flow always decreases under anesthesia. So as a consequence, biotransformation slows down under anesthesia. Okay? And that's something you always have to keep in mind. You've got to be careful about somebody who's already liver weak and not give them too many medications that they have to extract. If you have high hepatic extraction rates, which are highly active enzymes, will be dependent on hepatic blood flow. These are limited by hepatic perfusion, so these medications, if you drop hepatic perfusion, it really affects their clearance. And so they're called perfusion-dependent elimination. On the other hand, if you have low hepatic extraction rates, which have low enzyme activity, so it'll be less dependent on hepatic blood flow. These are affected by protein binding and increases in enzymatic activity. These are what's called capacity-dependent elimination. Yeah, the elimination can be described as either zero or first-order elimination, and I'm going to give you some analogies to it. The zero-order elimination is a form of elimination that's referred to that's independent of time or concentration. It basically can only process so many numbers of drug per minute. Okay? The example of that is ethanol. If you drink a lot of alcohol in one blow, it's going to take you a certain amount of hours to break this stuff down. There's nothing you can do to make it go faster. You drink coffee all you want. You can suck oxygen. I don't care. It won't work. You have only a fixed number of enzymes, so you can only break this ethanol down per time. So it takes a more linear approach on the graph. So a typical example of other medications that we administer, like phenytoin and aspirin. But the classic that most everybody uses is ethanol to describe this. Okay? What zero-order analogy looks like is imagine that you've got a bunch of kids that have to go to school, and then you can bring along the bus. Okay? And the bus limitation is that you can't cram all these kids in the bus. The bus only has so many numbers of seats. Okay, so that's basically your zero-order analogy. You only have a certain number of enzymes that can clear the drug. As soon as you put in a certain number of the kids, then basically the bus is full, and off they go to school, but it's basically a fixed number. Okay? The next bus that comes around picks up the next number of kids, and then clears it from there. So it's a fixed number of clearance per time. There is differences genetically in the individuals. It's called fast and slow acetylators. The fast acetylators have big buses. The slow acetylators have little buses. They have the special buses. Okay? So if you're a slow acetylator, you tend to stay drunk for longer periods of time. If you're a fast acetylator, you tend to be an alcoholic more often than not because you think that alcohol has no effect on you. So you tend to drink a lot more. Or some people, if they drink alcohol, it actually does some genetic biotransformation that makes them go crazy. And some people become hyper-aggressive and they fight and they do some stupid stuff. So, and that's from toxicity of the byproduct of an ethanol. Now, elimination on the first order process is directly proportional to the serum drug concentration. So at this point, there's enough enzymes to hit whatever you're covering, it'll take care of it. Okay, so it means that it has more than enough numbers to take care of whatever you throw at it. So it forms a much more gradual curve that rapidly gives you more of the elimination in half time, and it becomes linear when you do the log curve. Okay? Many more enzymes than drug. The majority of basically drugs are broken down this way. And my first order kinetic analogy is the lemmings. My friendly lemmings, I love these little guys. It says if you increase the number of lemmings on the edge of the cliff, more will fall out. Okay? So it doesn't matter the numbers. Okay? So lemmings is an unlimited number, can jump off. The greater the number packed together, the greater the number jumping off, which eliminates them very easily. They had some second thoughts. So. Anyways, pathways for metabolism. That's the next concept. Okay? There's 4 basic pathways to breaking down a medication: oxidation, reduction, hydrolysis, and the last one is in conjugation. The phase 1 reactions are taking the medication and altering it just a little bit, so then it will go to the second phase to make it water soluble. So the first phase is to set up the medication, break it in certain places to add something to it so they can later on be ionized and made water soluble. Okay? The reason it's called conjugation, okay, is that it's taking 2 things and joining them together. Okay? When you conjugate with somebody, it means that you're interacting with somebody, possibly sexually, in contact. Okay? So you have close contact with an individual. You're making 2 things that are separate into one. That's what conjugation means chemically. You're taking 2 chemicals and putting them together. The chemicals that you add to the molecule is an amino acid or a sugar, okay, a carbohydrate. Both of those will actually usually add ionized charge to it. So the molecule becomes ionized now. Okay? But the first step, which is the 3 steps, which is oxidation, reduction, and hydrolysis, or the phase 1 reactions, are what changes the drug's polarity and causes inactivation in many drugs. But ultimately, it's just the first step into making it a water-soluble agent. Most of these drugs, at that point, when they're oxidized, reduced, or hydrolyzed, they're not ionized. So they cannot be gotten rid of by the kidney at that point. It's only until you get into the phase 2, where you covalently link the highly polar groups, such as carbohydrates or amino acids, that you make it into an ionized, soluble agent that your kidney can get rid of. So let's go through each one of these steps. What is oxidation? Okay, oxidation is actually a fairly simple thing. It means that you're adding oxygen to the molecule. Okay? And when you add an oxygen to the molecule, usually you extract the hydrogen ions, usually 2 of them, to form water as a byproduct. And the other is you usually put a double bonded oxygen into it, a carboxyl group. Okay? So you got here, that's ethanol and ethanoic acid, which is a carboxylic acid group here. So you can add, and these are easily, you can add substance to that. So this is the first step. What the oxygen basically does is it makes the molecule lose electrons in the process, and it makes it more likely to want to accept another electron from something else, which usually shares, which is the conjugation process, which is the next step. Oxidation usually is done via the P450 system. The P450 helps donate an electron via the NAD system. And oxygen is a process that splits. The oxygen goes to form a water group and an R double bonded O group, okay, which is important. The examples of oxidative metabolism are there's different kinds. You have hydroxylation, which means that you just have a hydroxyl group that you're adding to it. You have deamination, which is you remove an amine group and replace it with a hydroxyl group. Desulfuration is you remove sulfur in the process, and you cleave it there. These are areas where the molecule tends to want to break organically more easily. And you also have dealkylation, which means that you remove a methyl group off it. This is called the demethylation reaction. Morphine and demerol are both examples of demethylation reactions. Demerol, which is meperidine, converts into normopyridine. Normopyridine has still toxicity associated, which is seizures. Versus morphine goes from an active state to a less active state, which is a normorphine. Normorphine is basically just a demethylation reaction. And then you have dehalogenation reactions where you actually break down a halogen group, which is chloride, bromide, or fluoride, which is what volatile anesthetics can do. So the different examples of oxidative deamination, and this is the actual demethylation reaction. You can see here that the methyl group here that's attached to the nitrogen group is broken and cleaved, and then what it does is it makes that molecule more likely to accept the conjugation process in the end. Okay, which we add next in the conjugation process is usually a carbohydrate or an amino acid. This is normopiridine from mepiridine. Okay, so again, it cleaves it here, and now you're left with just a nitrogen group freestanding. Okay, this is dehalogenation reactions where you actually cleave different portions. This one's actually halothane. The debromination or dehalogenation, it breaks down the bromide or the chloride. In this example, you're breaking off the actual chloride and bromide and cut it in half, and now you've left with a molecule called trifluoroacetic acid. You have other situations where you release fluoride and bromide off this, which can cause toxicity to the liver to that patient. Reduction processes basically are the next step, which is the process of adding electrons. This also involves the P450 system, but it can occur in low oxygen states. So it's something that you see, but rarely, thank goodness, in the liver. Hydrolysis is the next one. The hydrolysis doesn't require the P450 system. It adds basically water to the molecule, making it water soluble, and eventually it causes hydrolysis of glucuronide conjugates to take place. You can see the actual medication will break and cleave into different components by hydrolysis. Conjugation, which is a very important phase, which is phase 2, is a covalent linking of the highly polar molecule groups, such as carbohydrates and amino acids, and it makes the molecule much more water-soluble. Glucuronic acid conjugates with a lipid-soluble agent, leading to inactivation and water-soluble and byproduct as a consequence. So these are the phase 1 enzymes that are broken down. These are the ones that you have to think about. You have the cytochrome P450, the non-cytochrome P450, and the flavin-containing monooxygenase enzymes. In the cytochrome P50, you have the hepatic microsomal ones, the membrane-bound heme proteins, the mixed-function oxidase systems, the oxidative and reduction steps, and their enzyme inducers can take place, which means that you can actually activate these enzymes to become more active. So if you expose somebody to a lot of stuff, like if you expose that individual to high doses of caffeine, when they get a re-exposure to a medication that's similar to caffeine, that branch of the P450s will cleave that medication at a much higher rate than you expect. Okay? The monochrome P450 system, on the other hand, is almost all conjugation reactions. It's mostly taking place in liver. That's your pseudocholinesterase. And in other areas, pseudocholinesterase is in the bloodstream. And sometimes you have nonspecific esterases. You also have minor oxidation and reduction. And usually these are not enzyme inducible. And the last one is the flavin-containing monooxygenase enzymes, which are NADH, NAD dependent. And they take things like TCA and hydrogen 2 receptor antagonists, and they break them down. The phase 2 enzymes are the ones that we're talking about. They do the conjugation. And these are broken down into things called glucuronal S transferases, glutathione S transferases, N-acetyltransferases, and sulfotransferases. The way you have to know this is I don't expect you to memorize all the names. Instead, I just want you to know the transferases. If you see transferases, that means it's a phase 2 enzyme. That's how you keep it in your head. Okay? And the way you think about it is it's transferring one molecule into, and it's transforming it. It's squeezing it together and making it into something new. What they're basically meaning is they're adding the group here. This is a glucuronal S transferase, which means it's going to add the glucuronal group to it. This one's going to take a glutathione group. This one's going to add N-acetyl group. And this one's going to add sulfo, which is basically a sulfurous component to the group. Okay? N-acetyltransferase is one of the phase 2 reactions. This is what is the difference between a fast and slow acetylator. Okay, this is what genetic differences between individuals. If you're European, you tend to be a fast acetylator because our water in Europe got contaminated from poor hygiene, okay, and the water really was not drinkable. So they had to make it something to drink, and they made alcohol, which is either beer, wine, mead, whatever they used, okay, because it was really dangerous to drink the water. So most people that have genetic origin in Europe are fast acetylators, versus people that never had alcohol, like people in Central and South America and North America, when the first people got here from Europe, they noticed that when exposed to alcohol, they couldn't tolerate it. They would stay drunk for hours. That's because they're slow acetylators. Okay, so there's genetic differences between people. Okay, fast accelerators fall of zero-order kinetics, which is a big bus, the slow accelerators have the small bus. You can see how they break down the medication much more slowly. The problem with it is if you have slow accelerators, you can also get hepatotoxicity to certain medications, like isoniazid. The other one that's also associated with having problems with slow acetylation will be hydralazine and procanamide. So we give a lot of hydralazine to people. So I would be very careful about giving hydralazine to Native Americans because you may get into trouble with that medication. Pharmacokinetics of excretion, how does the body actually remove the medication? We're almost done here. This is basically eliminated by unchanging the drugs. Sometimes the pomade is a good example of that. It does it by exhalation. And sometimes medications come out of you cutaneously. Liver-wise, comes out the biliary system, kidneys, and glands. The biliary excretion basically takes the metabolites of drugs produced by the liver and then excretes it via the actual biliary tract. The biliary tract then it goes into the small intestine where some of it gets absorbed. If it's water-soluble, then it stays in the GI tract, but if it's lipid-soluble, it gets reabsorbed. Okay, but when it returns, it usually returns via the portal vein. Hopefully the hepatic cells will then convert that lipid-soluble agent into a water-soluble metabolite, which then goes back to systemic circulation and is broken down by the kidney. You get rid of it by the kidney. Okay? And the example of that, if you think about it, is bilirubin. When bilirubin, which is part of your hemoglobin, breaks down, it forms a compound called biliverdin. Okay? And biliverdin gets into your stool, and then it gets broken down by the actual bacteria and makes the color of your stool, which is slightly brown. But that thing is, which is bilirubin, at that point, is highly lipid soluble. So some of it gets back into your bloodstream. And when it gets back into your bloodstream, your body, your liver again breaks it down again into make it a water-soluble agent, and then excretes it out in your urine. That's why your urine has that slight straw color to it naturally. Okay? You can dilute it out by drinking a lot more water. You can dilute out the number of bilirubin that's in your urine. It's not creatinine. The creatinine doesn't really make that color. Okay? You can get byproducts like in rhabdo that'll make the color change into more of a darker brown color, but that's not the same thing of a normal urine color. Okay? Renal clearance, metabolite must be water soluble. It correlates to creatinine clearance. The lipid soluble agents are basically easily filtered, but they can't stay in the tubule because they get reabsorbed so fast, so your body can't get rid of it. So eventually renal excretion is dependent on glomerular filtration rate, the active tubular secretion, as well as the passive tubular reabsorption that's taking place. And basically pharmacokinetics, the way you have to think about it is it tells you how the medication works, and how the body attacks it. It'll give you the idea of the intensity of the drug effect, duration, the therapeutic range of it. It also will give you a variability. It can be described by pharmacokinetics. And I think it's really important to understand pharmacokinetics in your daily practice. So hopefully this lecture has helped you, and we're done with this section for today.